evaluation of coronary artery disease. Jamshid, please.
Good morning, and thank you, John, for your kind introduction. I'm deeply honored to deliver this lecture in memory of my distinguished colleague and cherished friend, Dr. Mario Verani. Dr. Verani has left an enduring legacy at Baylor and across the world through his pioneering contributions to the field of nuclear cardiology. Mario's presence is deeply missed, and his memory continues to inspire us. Yeah, this photo was taken probably about, 30 years ago or so. I always have great memories with my conversations with him, with working with him, and also in some of the retreats. I remember one particular one that he was supposed to deliver a lecture, but he spent 5 minutes describing the match between Brazil and another country, the soccer match, and how excited he was that Brazil has won. Anyway, so the timeline of FDA approval for myocardial perfusion tracers began basically in 1977 with the approval of Thallium-201. And this is about the time that I started my work and research in nuclear cardiology. Yeah, this is a younger version of me here in 1977 doing stress redistribution, planar Thallium-201 imaging. And as you can see, looking back, I think that we were looking at type of images that were like fingerprints, and we were making a lot out of them, actually. They were very diagnostic at that time, and now you'll see where we have gotten after so many years. Then after thallium, it was not until 1989 that rubidium-82 was approved by the FDA. And it is important to recognize that approval of rubidium preceded technetium, sestamibia, and technetium tetraphosphine development. And then in 2007, N13 pneumonia, that has been in clinical use for some time, was officially approved by the FDA. And as you can see, that there was a big interval or hiatus between the approval of the first PET tracer, rubidium-82, and ultimately approval of F-18 flurpiridaz. I would like to share with you the number of procedures per year that are done currently. Unfortunately, thallium is no longer produced because of its high radiation compared to the other tracers. Rubidium-82, approximately 200,000, or maybe some newer data shows that it could be up to 250,000 studies per year. And technetium SPECT imaging is about 6 million studies per year in the United States. So one wonders that if rubidium PET was approved even prior to the SPECT, sestamibia and tetraphosphine, why is it that it is lagging behind in terms of clinical use? And I think that it has to do with issues that I'll be discussing shortly. And the purpose of developing F-18 flurpiridaz was to actually circumvent the roadblocks that we had with the use of PET in a wider scale. Now here's the structure of flurpiridaz, and it shows that it is a mitochondrial complex 1 inhibitor. Therefore, it avidly attaches to mitochondria, and as you know, myocardium is a mitochondrial-rich organ. Therefore, it would be a great target for imaging. So the reason that we are excited about flurpiridaz is that it has a long half-life, about 109 minutes, and therefore it can be produced and distributed by existing network of regional cyclotrons as a unit dose. And that really distinguishes it from all the other PET tracers that require either a generator that is quite expensive or an on-site cyclotron. And it can also be in use in conjunction with treadmill exercise testing. So let's look at some of these. Here we're looking at the half-life of various PET tracers and their production. Here with oxygen 15 water, we need an on-site cyclotron. With N13 ammonia, again, we need an on-site cyclotron, but because his half-life is approximately 10 minutes, there were some studies that if you have a nearby cyclotron, you could still use it, but it wasn't really practical. With rubidium, you need a generator that is, cost is approximately $500,000 a year of a fixed cost, fixed overhead. And then with F-18 flurpiridaz, because of a longer half-life, the existing regional cyclotrons that are currently producing FDG, for instance, can deliver this tracer as a single dose to various centers. This is a whole body, the series of whole body images of a patient who underwent exercise injection, just to show that why we can do treadmill exercise testing. This is a treadmill exercise, and you can see that this poor patient was under the whole body imaging for 277 minutes. You can see that the myocardium is very well visualized up to about past 2 hours, but basically what we need for successful imaging after treadmill testing is that it resides in the myocardium for about 10-15 minutes to allow time for the patient to complete the exercise and then get under the camera. And you can see that the images are very good. Now, there are a few other interesting findings on this. For the first time we saw, when we did this study, we saw that there is brain uptake of flurpiridaz. It crosses the blood-brain barrier, and it could be actually a future use for this tracer in brain imaging. The other feature is that you can see that the background is quite clear. There is really not much background activity to interfere with the myocardium. The only areas of uptake you see are the exercising muscles, which is understandable, that the patient was doing treadmill exercise, so the muscles take up this tracer. Another important feature that distinguishes flurpiridaz from other tracers has to do with the high myocardial extraction fraction and the shorter positron range of this tracer. Let me give you a few, again, comparisons. Here we are looking at endpoint coordinates of various tracers, and this is like a point source imaging. Basically, you have a point source of these tracers, and you want to see how tight this point source is imaged. And you can see that depending on what we call a positron range, the point source coordinates are the best with F-18 flurpiridaz. And the reason is that the positron after emission travels only a very, very short distance before it annihilates and generates the gamma rays, while with, let's say, rubidium, it travels about 8.6 millimeters before it annihilates, and therefore by moving 8.6 millimeters away from the target already results in a blurrier image. So you can just compare these two, and you can see that what a difference there is in the spatial resolution of this tracer. So even though they're all PET tracers, but because of the positron range differences, they actually behave differently in terms of the image characteristic. Another important aspect that we have realized for some time is that the relationship between myocardial blood flow and the uptake of a tracer depends on the extraction fraction of that tracer. So here we're looking at a situation that with rubidium and technetium-based agents, because of a lower extraction fraction, we have a phenomenon that we call a roll-off phenomenon. So in a case that the patient has like 25% reduction of flow at peak stress compared to the normal region, it registers as only 10% reduction of activity. And that is the situation with this patient with LAD disease, that you can just see that there's a very minimal reduction of activity in the distal anterior wall. But the same patient that was imaged with flurpiridaz instead of sestamibi, you can see that The defect in the anterior wall is quite clear. It is much deeper or much more contrast in the defect, is much larger. You can actually see even the left atrium behind the ventricle here. Again, another feature of the high imaging resolution or image resolution of this tracer. Now, why is that? What causes this difference? Then if you look at the F-18 Flurpiridaz with a 94% extraction fraction, you can see that the relationship with flow is pretty much linear, and a 25% reduction registers as about 20% below the normal activity in the myocardium. So you can see basically the defect contrast with Flurpiridaz is double the defect contrast that you see with rubidium and technetium sestamibi. So our journey for getting Flurpiridaz through the finish line was a long one. We injected the first patient in the world, the first human volunteer at UCLA on October 2nd, 2007. It took us quite a while to get through under Lantheus Medical Imaging, get through the phase 1, phase 2, and phase 3 study. I had the privilege of being the PI, the lead PI on this project. Throughout this process, I endured it for so long, and then we got to 2017 that we had a little pause first, that the Lantheus ran out of money and ran out pretty much of interest in continuing this work until GE Healthcare took over, and then they were able to do the second phase 3 study, and which was successfully completed and was finally approved by the FDA on September 27 of 2024. I would like to go over these different phase studies that we have done with clear messages as to what we learned from them. In the phase 1 study, there were two of them. One that we looked at the dosimetry, biodistribution, and safety of Flurpiridaz after injection at rest. And the second study that was published in Journal Nuclear Cardiology in 2019 looked at the same parameters, meaning the safety, dosimetry, and biodistribution after injection at rest and stress, either treadmill exercise or pharmacologic exercise. Now, the findings are summarized here, but I'd like to draw your attention to the last on the list here, that basically based on this very detailed biodistribution and dosimetry analysis, we came to the conclusion that the maximum injected dose for rest stress imaging is set at approximately 14 millicuries. So that's what was the basis of developing protocols. So the protocols that we advocated at that time in terms of moving on to the phase 2 and phase 3 were first the rest pharmacologic stress imaging, which is similar to what we did with sestamibi low dose and high dose. So 2.5 to 3 millicuries at rest, and then after resting image, we had to put about a 15-minute waiting period before we go to regadenoson injection and imaging with the injection of 6 to 6.5 millicuries of the tracer. Now, the reason for this waiting was that there would be residual activity from the resting image that spills over to the stress image, and we wanted to minimize that spillover to less than 20%. But now I will be talking about how we can actually improve on this protocol and make it more practical later on during my talk. With exercise, we have to make the dose ratio higher, meaning that the same is given at rest, but a higher dose at after treadmill exercise. And also because the SUV of myocardial uptake after treadmill exercise is not as high as pharmacologic stress, then we had to put a longer waiting period between the two in order to, again, minimize the spillover from rest to stress imaging. Then in the phase 2 study that was published in JACC in 2013, We looked at diagnostic performance of Flurpiridaz versus technetium-labeled SPECT for detection of disease in a small group of patients, 143 patients. And then we moved on to the phase 3 study that consisted of 2 studies. The first one that was published in JACC in 2020, we looked at Flurpiridaz versus SPECT MPI for detection of disease in 755 patients. And as you know, FDA has a requirement of repeating the phase 3 study again to verify whether the findings of the first one were correct. And in the first one, we had some issues that FDA agreed to change our primary endpoint to comparison of Flurpiridaz to invasive coronary angiography as the main criterion, and then moved the comparison to SPECT as a secondary endpoint. So here, the aims of this, what we call a pivotal trial, or the last or the second phase 3 study, were to assess the diagnostic efficacy of Flurpiridaz for detection of coronary artery disease, defined by quantitative coronary angiography greater than or equal to 50% narrowing. And the secondary endpoints were to compare it to SPECT in all patients, which was the key endpoint, and then in the various subgroups of patients, in women, in patients with a BMI of greater than or equal to 30, and in diabetic patients, and also assess the safety of Flurpiridaz. Here are the key findings of this trial that were published in 2023 in JACC that shows the ROC curves for Flurpiridaz shown in green as compared to SPECT that is shown in red. And it shows that in the overall patients of 578 patients, the ROC curve, area under the ROC curve for PET was significantly better than SPECT. And then when you look at the various subgroups, the same trend is maintained. You can see that in women, in 188 patients, again, PET performed much better than SPECT. In patients with a BMI of greater than or equal to 30, again, PET, area under the curve for PET was significantly better than SPECT. And also in diabetic patients, we saw that the ROC curves of PET were better than SPECT. At the same time, we looked at some other features comparing PET and SPECT. PET is shown in yellow and SPECT in blue. We looked at image quality, meaning that the percent of the studies that were interpreted as excellent or good. And we can see, again, the PET did much better than SPECT on the resting images, on stress, pharmacologic stress images, and exercise images. And then we looked at diagnostic certainty that was defined as the percent of the studies that we call definitely normal or definitely abnormal, as opposed to probably normal, probably abnormal, or equivocal. And you can see that, again, PET did much better than SPECT. And very importantly, the amount of radiation to the patient, or radiation exposure in millisieverts with PET, was half of that of SPECT. And that actually is a number that is getting reduced even further with various types of acquisition and processing protocols. We currently are at the level of about 3 millisieverts of radiation. And if you do stress only, which is one of the very good protocols with this tracer, stress only, you can actually do a study with less than 1 millisieverts of radiation to the patient. So showing you some examples, this is an example from the publication in JACC in 2020, a patient with left main disease that the SPECT study was interpreted as being entirely normal by a panel of blinded observers. As you can see, there's no definite perfusion defects here, but the PET scan, the PET with the Flurpiridaz, shows clear-cut defects in the distribution of the left main. As you can see in the anterior wall, in the anterolateral wall, there are large defects and extend all the way to the apex. So this patient with left main was missed by SPECT, but was appropriately and correctly diagnosed as a positive study by Flurpiridaz. Here's another example of a patient with LAD disease that, again, the SPECT study does not show any perfusion abnormality, but the Flurpiridaz study shows clear-cut defects in the LAD territory that corresponds to the findings of angiography. So it was a true positive by Flurpiridaz and false negative by SPECT. Now another study, this is a patient who had a history of MI. Looking at the SPECT study, there is a defect that appears to be non-reversible in the inferolateral wall. So it was read as a normal, or as a probably abnormal study, as a non-reversible defect in the inferolateral wall. But you can see that the quality of the image with Flurpiridaz is quite different. You can see that the defect is not probably abnormal. This is a definitely abnormal study with very clear-cut abnormal perfusion. You can see the papillary muscles in the myocardium, and you can see very clear-cut reduction and maybe slight reversibility in the defect also that is better seen by Flurpiridaz PET as compared to SPECT. Here is another example of a patient with a significant right coronary artery disease that was missed by technetium sestamibi SPECT, but was appropriately diagnosed as a positive study by Flurpiridaz PET. You can see that differences are quite clear between what we get with SPECT imaging as opposed to Flurpiridaz images. Now, if you look at the movie format, obviously we can do gated study. We can see that the inferior wall at the time of stress is not contracting. It's very, very decreased contraction, especially in the proximal portion with the Flurpiridaz. But on the SPECT study, you can see that the motion of the ventricle is completely normal post-stress. So not only it was missed by the actual perfusion images, but also by wall motion, we couldn't see this. Well, the reason that we can detect better with Flurpiridaz as compared to SPECT is that we are doing wall motion imaging actually at peak stress compared to SPECT that we wait about 15 minutes to half an hour after stress. Another example of a patient with a BMI of 34 who had a 79% distal LAD disease and 252% proximal and mid lesions. And this patient was, again, by the SPECT study, was considered by the panel of blinded observers to be a normal study, while you can see with Flurpiridaz that there is a clear-cut defect in the distal LAD territory that corresponds to this patient's disease. And this is another example of a patient with a BMI of 52, underwent pharmacologic stress, and the patient did not have any disease, only 35% proximal LAD. Technetium labeled SPECT study was interpreted as definitely abnormal by showing reversible defects in the inferior wall and in the apex, as you can see on the vertical long axis. However, which was a false positive because the patient did not have any significant disease. But you can see that on the Flurpiridaz study, there is no perfusion defect, and the study was appropriately called as being a negative study. Question of whether Flurpiridaz PET actually performs better than SPECT, even in in the era of CZT SPECT. This is an unpublished study, a study that will be published hopefully soon, that looks at the differences, and you can see that PET Flurpiridaz performs better than SPECT, regardless of the type of camera, either with the Anger camera or with CZT technology. I'd like to review a few other studies that were done and that were sort of a subgroup analysis. This particular study was done on all patients in the phase 1, in the phase 3, the first phase 3 study, looking at the influence of left ventricular size on the diagnostic performance of PET versus SPECT. And the point here is that if the ventricle is small, with the fuzzy images of SPECT, and maybe by the same token with PET rubidium, then the small defects may be missed, and therefore the sensitivity and the overall performance would be less than Flurpiridaz SPECT. And this study proved that with the LV volume of less than 113, we see that there is a very big difference between PET and SPECT, while the difference is diminished when the ventricle is larger. Now, this points out that the reason that in women we see improved diagnostic performance may be partly related to the size of the ventricle, in addition to the issue of attenuation and attenuation artifacts. But also, it points out that even in male patients who are smaller and they have smaller heart, then the diagnostic performance would be better with Flurpiridaz as compared to SPECT. So as you well know, one of the very important features of PET imaging is quantification of myocardial blood flow. So we did take the opportunity early on in 2014 to look at the modeling of flow with Flurpiridaz. It was published in Journal of Nuclear Medicine. And then we took that model and then applied it to a larger group of patients. First, we did two types of what we call quantitative analysis. One of them is what is the polar map approach to detection of defect. This is relative perfusion. It is not any quantitation in terms of flow rate, but it is just a distribution of activity around the myocardium. And this polar map approach with one of the programs that we published with Dr. Packard, my dear colleague, as the first author. This was published in the Journal of Nuclear Cardiology and shows that with the polar map approach, we can detect the defects. Here is a normal study with a normal polar map, and here is a patient with basal lateral wall defect, left circumflex disease, that very clearly shows a blackout in the lateral portion of the polar map corresponding to what the patient's disease was and also what is seen visually. So this basically objectifies interpretation. But the next step was to go and look at rest and stress myocardial blood flow and current myocardial flow reserve. And one of the, again, the distinct features of Flurpiridaz is that because of its high resolution, you can actually get to the segmental analysis of flow. So we can actually measure flow in each one of the 17 segments of the myocardium. So here, another study that was published in the Journal of Cardiovascular Imaging, Journal European Heart Journal of Cardiovascular Imaging by Dr. Packard as the first author, you can see that the area under the curve is compared with various types of analysis. First is just perfusion quantitation alone, the area under the curve, and then is that if we add to it segmental stress myocardial blood flow on a segmental basis, or stress myocardial blood flow looking at the territory, like a 3 territories, LAD, left circumflex, and RCA, and then myocardial flow reserve on a segmental basis and territory basis. When you look at all of this, you see that the biggest distinction or incremental information over and above perfusion analysis alone comes from stress myocardial blood flow on a segmental basis. That was significantly better than perfusion defect analysis alone. And also on a territory basis, stress myocardial blood flow is quite diagnostic. So this basically confirms what has been known previously in the literature, that the myocardial flow reserve may be misleading in some patients, and it is more diagnostic to look at in terms of the regional disease, to look at the stress myocardial blood flow. Now, if you look at a group of patients that had intermediate disease of 50 to 69%, you can see that these differences are even enhanced and exaggerated here. You can see again perfusion defect alone with the area under the curve compared to the area under the curve. When you add to perfusion quantitation, you add the stress myocardial blood flow analysis on a segmental basis, and you can see that there is a significant improvement in diagnostic performance. One of my goals as the lead PI was to make sure that we have all the major manufacturers of software with quantitation of PET, that they develop their software to the point that at the time of approval, they are available for distribution and use. Unfortunately, we were able to complete that. And here is a study that compares, again, first authored by Dr. Packard, and it was actually published on November 3rd, just a few days ago, that is comparing diagnostic performance of Flurpiridaz PET between 3 different software packages. One is the Emory Toolbox or ECTB. The other one is 4DM from Michigan and QPET from Cedars-Sinai. And here we're looking at all kinds of comparison between these, looking at the MFR, segmental myocardial blood flow, on a per patient basis, on a pooled data of vessels and each vessel individually. And you can see that these the plots show that they really correlate pretty well. And if you look at the myocardial flow in patients with greater than 70% stenosis, you can see that obviously the diagnostic performance in the area under the curve improves. And also, again, the 3 software packages compare very nicely with one another. So I believe, based on the data that I presented to you and the research that we had done over the past 17 years, that we can come to the following conclusions: that F-18 Flurpiridaz is a novel PET myocardial perfusion imaging agent that has been recently approved by the FDA for clinical use. It is clinically safe and well tolerated, and because of its long half-life, it can be distributed as a unit dose and can be used in conjunction with treadmill exercise testing. Because of its higher image resolution, its diagnostic performance is higher than technetium-labeled SPECT imaging for diagnosis of disease, especially in females and obese patients. Its better image quality increases the confidence of image interpretation. It is associated with lower radiation dose to patients versus technetium-labeled SPECT imaging, and segmental analysis of myocardial blood flow allows improved detection of coronary artery disease as compared with perfusion defect analysis alone. And the fact that F-18 Flurpiridaz has the potential of extending its use to a larger patient population. So let me talk about this potential of the larger patient population a little bit. Here we are looking at one possibility, that a lot of these PET scanners that are existing currently, you have 2,500 PET scanners and in hospitals across the United States, that collectively they perform 2 million scans per year. Out of these 2 million scans per year, 82% of them are FDG studies and 7% of them are rubidium PET. So we have all of these PET scanners available, and if we have a unit dose delivery, then we can use these PET scanners at extra time on them. I know that a lot of them are busy, but we can start actually getting our feet wet, so to speak. We're doing Flurpiridaz in the existing PET scanners, and gradually I think that this will evolve into getting a dedicated PET for the cardiac studies and use Flurpiridaz for that purpose. I would like to end with the path forward. We have a lot of work to do still. First is physician training for interpretation of F-18 Flurpiridaz images. I am indebted to 2 societies, American Society of Nuclear Cardiology and SNMMI, Society of Nuclear Medicine and Molecular Imaging, for their role in expanding and basically promoting use of F-18 Flurpiridaz. And specifically, I'd like to thank Dr. Al-Malad, past president of ASNEC, for conducting so many different workshops that train physicians and webinars that train physicians locally and internationally on interpretation of these images. And then Dr. Charan Tataway, the current president of ASNEC, that during her speeches all over the world, including the one that I attended back in India just a few weeks ago, she basically highlights as one of the important developments in the field of nuclear cardiology. And also Dr. Marcello Di Carli is the editor-in-chief of Journal of Nuclear Cardiology, who is dedicated and he's very enthusiastic about this development, and he has dedicated a single issue compendium on the use of F-18 Flurpiridaz, or the potential of F-18 Flurpiridaz. So I'm indebted to these individuals and many others for carrying the torch forward in the clinical application. Now, there are some issues with whether we can shorten the imaging protocol. I think one of the most promising ones are the one that was published by, again, Dr. Charan Tataway, that shows that we can, since our concern is the spillover from rest to stress image, and we have to wait until it decays enough. So the idea was that instead of waiting to decay, so why don't we just subtract the rest image from the stress image and then do them back to back. And this study shows very nicely that by doing a back-to-back study and image subtraction, they get the results pretty much on the line of identity with a relative tracer uptake, and also myocardial blood flow is pretty much on the line of identity by doing this image subtraction versus not doing the image subtraction. Now, GE is very active in expanding distribution of Flurpiridaz and working on getting reimbursement. So the summary of their activities is here on this slide, that they're expanding the network of radiopharmacies to ensure reliable supply and timely delivery to our customers. Overall, customer adoption has been progressing well, supported by the favorable reimbursement and updated clinical guidelines, and is focused on optimizing workflow, scaling production to meet growing demand. Flurpiridaz is used currently in the United States across all the outpatient cardiology, different types of practices, such as outpatient cardiology practice, academic medical centers, such as here at Methodist, and also integrated health systems. And they have been successful in getting a Medicare reimbursement for this tracer, and they're working very hard on getting reimbursement by private insurance companies. A few of them have agreed, and the number of companies are expanding. And finally, getting out of the US and going to the global impact, I'd like to quote two slides from the work of Dr. Al-Malad. That one that was published in the compendium in March of 2025 in Journal Nuclear Cardiology, looking at the global distribution of PET and SPECT. And here you can see that the more green we have, the more units are available. So obviously, there are many more units per 1 million of population, 3.54 of SPECT compared to PET, that is 0.739. So I think that the hope is that first we would use, but by the way, of these available PET systems, what I showed earlier, just only a minority of them are used for myocardial perfusion imaging. So our hope is that this will actually be expanded. We can use more of these PET systems for Flurpiridaz myocardial perfusion imaging. And obviously, I don't think that PET will ultimately replace SPECT. I think that SPECT will continue to have a role in myocardial perfusion imaging, but I think that there will be a shift away from SPECT in certain patient populations, like what we showed in females and in patients undergoing pharmacologic stress or obese patients, that I think that PET would be a much better choice than SPECT. Now, the global impact, again, shown by Dr. Almala in this compendium, is very nicely shown here, that it basically matches the challenges and the opportunities that we had in the United States, except that the challenges for adoption worldwide are a bit more complex. The regulatory approvals are harder. The manufacturing and distribution is more challenging. The reimbursement and getting the cost of the tracer is quite challenging also, because we cannot maintain the level of reimbursement that we are getting currently in the US worldwide. And also, again, training and expertise of individuals is an important goal. Again, the Society of Nuclear Cardiology and Dr. Almala specifically have taken a very lead role in the training of the individuals. Well, I'd like to end with one slide that came to our mind last night at dinner time. We were talking about Dr. John Mamarian's love for pictures and for galaxies. So I wanted to share a picture of a photo that I took just recently of the Milky Way. And here we can see a bright star, or not star, it's actually a planet. There's a bright light, and that is Jupiter. So I think that linking that, in a way, I think that Flurpiridaz is a bright light in the field of non-invasive cardiac imaging, and I think that it offers a great opportunity for us to be able to expand the role of PET in management of patients and non-invasive detection of coronary artery disease. Thank you very much for your attention.
Jamshid, a wonderful talk on a very important topic. I really congratulate you on all the work you've done over the last, decade or more with pursuing this agent and getting it finally to the market. Getting it to the market. Can you not hear me? I'm pushing the button.
Testing 1, 2.
All right.
Nothing ever works.
Anyway.
Again, thank you for a wonderful lecture and all the work you've done with Flurpiridaz. I just have several questions. One question is, Flurpiridaz, based on its, extraction fraction and everything else, and its better spatial resolution, better sensitivity, better defect size, identification, all of these things. One thing I still don't understand, though, is why the specificity of PET at least in the phase 3 studies was really no better than SPECT.
Yeah, very, very, very good question. I think that we have looked into that quite extensively. I think it had to do, actually it came as one of the comments to our publication in JACC, and then I had to write a reply to it. And so I wrote all my points in that reply. So in summary, I think that when we looked into it, we found out that part of it was related to physician training. Even though our panel of experts were trained as to how to interpret images, but still there were situations that they were read because artifacts occurred. These artifacts were related to misregistration, basically, mostly. Overall, Flurpiridaz is more sensitive to misregistration because of its high resolution than rubidium and SPECT. The other thing that occurred was that because of a higher resolution, we see apical thinning very clearly. And in some of these cases that were read as false positive, that were false positive, were the ones that the apical defects were actually interpreted as being abnormal. Now we know how to treat the apical defect. I mean, just if it is not reversible, it is contracting normally. That would not be a real defect. But I think that the problem, the most important problem lies in the use of our gold standard. Our gold standard was greater than or equal to 50% narrowing by coronary angiography. And we very well know that anatomic definition of coronary disease and its correlation to perfusion is not ideal. We see, because of the use of 50% cutoff, we had quite a few patients between 50% narrowing or patients even with 40% narrowing by coronary angiography who showed distinct defects. And then they had to be called false positive. But whether those are really false positive or not is debatable. I would say that those 40% lesions or 45% lesions that showed a definite perfusion defect, those were actually true positive. But because we had to use the 50% cutoff, then they were called as a false positive study. So I think because of all of these features, I think that the specificity was driven down and it became very close to SPECT. But I think in the real world, with training, with more attention to artifacts, and recognizing that some of these may be real disease, I think that the specificity could be quite high. In practice, I think if you do a Flurpiridaz study that is clearly positive in the LAD, and they do an angiogram and they call you and they say, oh, well, this is only 40%, your recommendation would be do an FFR. Get in there and take a look at the IVUS and see what is going on. And you'll probably find that they're more severe than just a simple coronary angiogram shows.
You know, that's a very, it's still, what the heck? That's a very good point. I mean, it would have been nice if they had done FFR.
Are actually in the trial instead of looking at just anatomy, because like the Pacific study where they actually did FFR on everybody, the correlations I think were much better in terms of, specificity and such.
Exactly.
So I think that's an important point. So that brings me to another point about anatomy, because, just as PET is evolving, and I love to see it happening, in terms of what we're doing. We have CTA on the other side also evolving in terms of doing FFR non-invasively, in terms of doing quantification of plaque. And where do you see all of this kind of fitting together in terms of when we should approach patients in terms of doing, a CT angiogram versus doing a PET study?
Yeah, I think that is also a very good question. As you know, I'm a practicing cardiologist and deal with patients every day. And I think that I use PET mostly as a reliable indicator of whether there is perfusion deficit and the patient needs intervention. But obviously, it doesn't show patient has disease or not. So in my practice, I use coronary calcium and either that or CTA, just to establish early disease or the fact that the patient has disease and encourage them to get into risk factor modification. And then I think that one of the interesting things with CTA is that you can also do plaque characterization, and that is under study whether plaque characterization can help you with management, that you will be more aggressive in certain patients, and you can get rid of soft plaques, or it can diminish the volume of the soft plaques. So I think that it has a different role. I think that as a guide to whether the patient needs an invasive coronary angiography and subsequent treatment, I tend to rely more on PET than on CTA or coronary calcium.
I totally agree. I think in people with more advanced disease, perfusion imaging is really the way to go, and be able to better identify what vascular territories are in trouble.
So great talk, Jamshid. So questions about the flow. A lot of people are looking at this, and initially in the Aurora trial, you did not analyze the flow data. but then later on in the GNM paper, you showed different cutoffs. So where is the cutoff compared to what you have been seeing with rubidium, for example?
Right. I think that in that paper that came out on November 3rd, we're looking at also different cutoffs for depending on the software that is used. There are two things. Number one is that the cutoff for myocardial flow reserve and stress flow is different with flurpiridaz than rubidium. We can't apply the same cutoff that we're using for rubidium. Because of a higher extraction fraction, actually the threshold has moved up. So we see higher flows at stress measurement, and we see higher myocardial flow reserves with this tracing. So we shouldn't be surprised that we see that the numbers are higher than rubidium to start with. And then, depending on the type of software that you're using, various cutoffs are published now that have been validated. So I think that my recommendation is to use those, although they are not much different, 2.2, 2.15, so forth, but I think that they're all well established. And I would suggest that depending on the type of software that you're using, you use the appropriate cutoffs for better diagnosis.
Okay, well, if there are no other questions, again, thank you so much for